What fertility preservation options exist for cervical cancer radiation? When facing cervical cancer, especially when radiation therapy is part of the treatment plan, many women wonder about their options for preserving fertility. Radiation therapy can significantly affect the ovaries and uterus, potentially leading to infertility. However, there are several strategies available to help maintain reproductive potential. One of the most established methods is oocyte and embryo cryopreservation. This involves ovarian stimulation to mature multiple eggs before radiation treatment. Once the eggs are ready, they can be retrieved and either frozen as unfertilized oocytes or fertilized with sperm to create embryos for freezing. These frozen eggs or embryos can later be used in vitro fertilization, allowing for pregnancy either through a gestational carrier or, if the uterus is still functional, carried by the patient herself. Typically, only one cycle of stimulation can be performed before starting cancer treatment, which may limit the number of eggs retrieved but still provides a chance for future pregnancy. Another option is ovarian tissue cryopreservation. This experimental technique involves surgically removing and freezing ovarian tissue before radiation. The tissue can be reimplanted later to restore ovarian function and fertility. This approach is particularly beneficial for women who do not have enough time for ovarian stimulation or have hormone-sensitive cancers that prevent it. Ovarian transposition, also known as oophoropexy, is a surgical procedure that moves the ovaries outside the radiation field. This helps reduce radiation exposure and preserve ovarian function. While it does not guarantee fertility preservation, it can significantly decrease the risk of ovarian damage. The success of this method depends on the precision of the surgical technique and radiation planning. For women with early-stage, low-risk cervical cancer, conservative surgical approaches may be an option. Procedures like radical or simple trachelectomy remove the cervix while preserving the uterus, allowing for the possibility of carrying a pregnancy. Neoadjuvant chemotherapy followed by fertility-sparing surgery might also be considered for slightly larger tumors. There are also experimental uterine-sparing radiation techniques that aim to minimize radiation exposure to the uterus and ovaries. These methods are still under investigation and should be considered only in clinical trials. For those who may lose uterine function due to radiation, surrogacy is another avenue. Women can still achieve pregnancy through assisted reproductive technologies using previously preserved oocytes or embryos carried by a surrogate. It is essential to understand that the success of fertility preservation varies based on factors such as age, cancer stage, and treatment specifics. Early referral to reproductive specialists for counseling before starting radiation therapy is crucial. Patients should receive comprehensive information about the risks and benefits of each option. Overall, preserving fertility in women undergoing radiation for cervical cancer requires a collaborative approach involving oncologists, reproductive endocrinologists, and surgeons. This ensures that patients receive the best possible care while managing their cancer treatment. Always consult healthcare professionals for personalized advice and guidance tailored to individual circumstances.